My name is Eric Nestler, and I'm professor of saxophone at the UNT College of Music. Today, I'll be assisting Dr. Sajid Surve in addressing musculoskeletal health. You just heard a short performance of the second movement of the sonatine by Maurice Ravel, transcribed for saxophone. That wasn't too bad, but this is how I played 2 years ago in 2014. In this video, you can see unwanted facial movement and a slight scooping of the tongue. Here's another example of me simply attempting to perform one of the easiest notes for the saxophone. What you are seeing and hearing is called dystonia. More specifically, this is a clear example of embouchure dystonia. It really looks like muscular chaos, doesn't it? Dystonia is a movement disorder that affects the nervous system and one's muscles. Embouchure dystonia affects the muscles in the lips, the tongue, the neck, anything that creates an embouchure. Yet, there is no pain. Embouchure dystonia can be so severe that it can affect non-musical activities, like taking a drink from a glass. This is akin to forming an embouchure. It can also affect something like whistling. The movement you saw in that video is not gentle. In fact, I would characterize it as being quite violent. As far as performers, dystonia is a death sentence, but it doesn't have to be, especially if it is caught early on, ideally as soon as one notices strangeness in one's playing. And this is the primary point of my presentation today. As performers, when we notice that something doesn't seem or feel quite right, seek help, first from a trusted pedagogue, but if the problem persists, consider seeking the advice of a medical professional. I really think I started noticing dystonic symptoms in my own playing when I was an undergraduate student, certainly when I was a graduate student in my 20s, but I didn't know what it was. I simply assumed I wasn't practicing long enough, hard enough, or even correctly. Eventually, I discovered a way to compensate, which kind of worked for much of my professional life, but it was always iffy. I always had a question in my mind. Will it work today? In 2008, I saw my playing quickly devolve through the matter of months so that by September, I could no longer produce a basic sound on the saxophone without biting myself in a very violent way. So I tried to make it work for the next 4 years, but eventually gave up. I sought advice from my primary care physician, who referred me to a neurologist, who referred me to another neurologist, who prescribed Botox injections, considered by some to be a method of maintaining dystonia. Later, I sought clinical help from an acupuncture doctor specializing in both Eastern and Western styles of medicine, which helped tremendously. I also sought the advice of a chiropractor and a specialist in movement therapy and ergonomics. And finally, I met Dr. Surve at the UNT Health Science Center in Fort Worth. Along this arduous journey, I gained valuable information from each professional who tried to help me. In working with Dr. Surve, he suggested 2 courses of action First, releasing the muscular tension in the culprit muscles, a treatment that he applies in a clinical visit to his doctor's office. One such treatment looks kind of like this. Forgive me. He takes his finger and sticks it into my mouth at the base of my tongue. The second is a TMJ stretch that looks like this. Both can be quite painful. The second course of action suggested by Dr. Surve is incorporating the idea of cross-training. In my case specifically, Dr. Surve suggested that I practice the flute in addition to my daily routine of saxophone practice. The techniques necessary to produce a tone, articulate a sound, and be expressive with the flute are similar to that of a saxophone, but not exactly the same. In effect, by practicing the flute, my skills of saxophone performance are improved. One of Dr. Surve's associates at the UNT Health Science Center, Dr. Yeyin Lee, portrays the process as a way of confusing the brain. Before my life with dystonia, I performed solo recitals in North America, Eastern and Western Europe, Africa, Asia. I even performed in Carnegie Hall. All the while, I noticed strangeness in my playing and difficulty performing specific techniques. For a variety of reasons, I waited much too long before seeking help. As dystonia began to dominate my musical life, I found myself practicing more and more, up to 6 hours a day. But it got worse and worse. I tried to make it work on my own, but with very little success. So, as teachers of young musicians and instrumentalists, be on the lookout for strange conditions that normal pedagogical advice doesn't fix, like excessive and unwanted movement in the face and or hands, when what would be considered normal practicing doesn't help. Consider seeking the advice of a medical professional, and don't wait.
So we've already met. I am Dr. Surve, and I am the medical director for the Texas Center for Performing Arts Health. We have clinics in Fort Worth where we see the general population, and my practice is probably about 70% performing artists, whether that's musicians or dancers or theater performers. I also have a clinic up here right on the UNT Denton campus within the Student Health and Wellness Center, where we take care of students within the College of Music, all 1,500 of them. And we provide medical care for them when they have an issue that relates to their performance. I've been doing this for about 10 years. I'll tell you a little bit more about my background in a moment. But first, I just want to, again, thank Dr. Nestler for sharing that story with us. As I said earlier, it takes a lot of courage to come up here and share that type of a story with an audience. So I definitely appreciate him sharing his story with us this morning. But what I want to get across to you is that Dr. Nestler is not alone, not by any means, all right? When it comes to professional musicians, the issue of musicians' dystonia affects around 1% of the musician population. In medical terms, that's an astoundingly large number, because in the general population, focal dystonia is essentially unheard of. It's almost unheard of in the general population, but in the musician population, 1%. So if we say, Department of Labor statistics say that there's about 175,000 professional musicians in the United States, that's almost 2,000 people who are suffering from some type of dystonia related to play. And the point that he made is a very important one, which is the question of the issue of not waiting, right? Getting what we can see with musicians' dystonia, but really any musculoskeletal problem, is that the key to success in treatment is early intervention, right? The sooner we get at this problem, the better chance we have of conquering it, the more treatment options you have, the earlier on into the course of symptoms you have more options available to you to be able to address these symptoms. And so the issue of not waiting and getting help as quickly as possible is one that really needs to take hold within the music community. And unfortunately, as a musician for 30 years and a physician who treats musicians for 10, I can tell you that the culture of music is not one of going to seek help immediately as soon as you experience symptoms. Now that's not necessarily your fault entirely, because when you go to seek help, I can say also from being on the other side of the coin that the medical community is not fully equipped to deal with musician injuries because they don't necessarily understand the amount of forces that, and demand that you place on your bodies in order to be able to produce the type of music that you do. So work needs to be done on the medical side of the equation, but that does not mean that we should just delay longer, right? I'm here, I'm in the Metroplex. I'm the only performing arts medicine clinician in the DFW Metroplex. But I'm available. I have patients who come to me from all over the state, from all over the country. They fly in to come see me if they need help. So the Texas Center for Performing Arts Health, our clinics can be a resource for you if you have somebody who you feel that they need help, specifically from a music medicine practitioner. So this grainy, awful photo is of Richard M. Bacharach. He was a performing arts medicine physician in New York. And he was a very private person. This is literally the only photograph of him that I know of that exists in a digital format. And he was a very private gentleman. He's the one who got me my start. I started working with him 10 years ago when I was a resident in New York. And we, through our collaboration, were able to treat performing artists of all stripes, musicians, dancers, all skill levels. And he really taught me a lot about this profession and steered me on a different career path. And over time, I've now taken it on the mantle on my own, and eventually landed myself here at the Texas Center for Performing Arts Health, where we've been able to render our services for the DFW Metroplex and beyond. The main thing I want to talk about today, in kind of building on what Dr. Nestler was talking about, is this issue of musculoskeletal disorders. Now, musculoskeletal disorders from an ergonomic standpoint are not a mystery, right? We understand that there's factors that play into getting injured from a musculoskeletal perspective. And the equation goes like this. You take force plus posture plus repetition over time equals pain. That's the recipe for musculoskeletal disorders. And so what do we mean by that? Well, force, I use a trombone intentionally because here at the Texas Center for Performing Arts Health, we study these instruments to look for the forces, right? So when you play an instrument, the instrument is imparting some type of force back onto your body. In the case of a trombone, the weight of the instrument tends to lay on the shoulder, on the left shoulder, and then you push the instrument into your face. So the main spots where you're going to have force are on the lips and the face, and on the left shoulder where the instrument sits on the shoulder. And so it's not a surprise then that when we look at where do trombonists develop pain, it's in the face and on the left shoulder, right? Because this is where the forces are interacting with the body. And so we have done study on several instruments. We've looked at piano, and not surprising, the hands are where pianists tend to develop pain because that's where the forces are. When you're playing on the keys and pressing into the keys, the force is being absorbed by your hands and fingers, right? If you look at the clarinet or oboe, we see that the right thumb is where the forces are because that's where the instrument interacts with the body right there. And so that's where the forces are going to tend to be. So we have some ideas of where these forces are involved. We also understand that there's other factors that play into the forces, right? Because if we look at piano, for example, we know that if you're a pianist who has very large hands, even though you're playing very intensely, you may not necessarily develop pain, versus somebody who has smaller hands or a smaller hand span is more likely to develop pain, largely because the forces are greater, right? If you have to stretch your fingers as hard as you can to reach the keys, then the forces go up, right? If you're a trombonist, we know that females tend to have more shoulder pain than males. But even if you take the gender piece out of it, if you have broad shoulders, you have less pain than if you have narrow shoulders because the force is distributed across a larger surface area, right? So what we get from this is that each instance is a unique instance of one instrument and one instrumentalist, right? It's the interaction of these two together that is going to potentially produce pain over time. And the posture we kind of intuitively understand, right? Posture is the forces that rise up to meet the instrument, and we understand that if you have poor posture, then the forces are not going to be distributed as optimally as they can, and so if having poor posture is going to potentially lead to pain. So we can improve posture to potentially help with musculoskeletal disorders. Then there's the repetition piece. So repetition says, okay, so you have forces that are maybe ideal or less than ideal, and you have a posture that's going to come up to meet it. Now you're going to go and do this task for some period of time, and so if you do the task more, right, the more time you spend on that task, the more likely you are to develop symptoms or pain. And so this is where you as music educators need to come into the equation, because you are the ones who are directly setting the tone in terms of repetition, right? As the band director, as the choral director, as the marching band director, as the orchestra director, you set the pace in terms of what's going to be played and when it's going to be played. You also set the tone because you're the leader of that ensemble, right? And so your students look up to you, and so if you set the tone to say you need to practice 8 hours a day, and you're then creating a culture where the students need to practice more and more and more, and you're trying to set the tone that they need to put a lot of repetition into their instrument, then we're creating potentially an environment where we might see more symptoms. And cutting back to the culture piece, this is going to produce potentially pain. And so as the culture leaders, as the leaders of your ensembles, how you handle this situation when a student comes to you and says that they have pain is very important, because if you tell the students to just blow it off, or then you're setting the tone that you don't talk about injuries in this setting. And so we need to change that culture to say, yes, you can get help. There's practitioners who can help you with this problem. We can get you help. We can thank you for telling me about this early, because we can intervene better now that we know that it happened early, right? So there's ways that we can set the tone from the top, because culture always starts from the top. So we want to try to create this culture where we're looking at these musculoskeletal injuries and trying to have a culture where we recognize them, we recognize that they need help and can be helped, and that we are making referrals where we need to make referrals so that students can get help before the symptoms progress to a point where it's going to be potentially detrimental to their career. So ultimately, at the end of the day, we have our recipe for musculoskeletal disorders. But what I want to share with you, most importantly, is that these problems are, in fact, preventable. And once we understand that they're preventable, we can take the steps to prevent these musculoskeletal injuries. So that's the conclusion of my talk. Thank you very much. Thank you. I'm going to go ahead and hand off to our next presenters, Dr. John Murphy and Dr. Amin Amlani.